Great. Good evening, everyone. I think we are live. So welcome to the October meeting of Ealing's Health and Wellbeing Board. I know that we've got at least one person still connecting and a few others due to join, but it is 6 o'clock, so we will kick off. I have had apologies from a couple of councillors, Councillor Mason, Wall and Nagpal. I don't know, Keith, if we have any other apologies we need to note?
None that I'm aware of, no.
Right, Councillor Shaw should be joining us as a substitute shortly. But as ever, technology prevents timely and speedy joining. Does anyone have any declaration? Oh, sorry, urgent matters. There are no urgent matters, which is why I skipped it. Does anyone have any declarations of interest they particularly need to make this evening? No. Excellent. There are no matters to be considered in private. So are we happy with the minutes of the June meeting? Yes. Excellent. No dissent. Wonderful. We can confirm those as an accurate record. And Matt, we can hand over to you for the Healthwatch update. And there's a couple of really good pieces of work that you've done. So if you'd like to take us through that, that would be great.
Fantastic. Yeah, thank you so much. We do have quite a lot going on, so I'm going to try and provide a brief overview of each kind of area of our service, and I'll start with our patient experience program. So we've just finalized and we're publishing the Q1 patient experience report. For this report, we gathered over 1,200 reviews again, and 74% were positive, so 900 positive reviews in total. Patients' issues with their GP surgery this quarter were very similar to that and of previous quarters, focusing around staff, customer service, administration and access issues, and to some extent treatment and care, although this is a bit of an anomaly, I think. So the recommendations for this report are largely for us as an organisation, actually, about how we can further improve representation within the patient experience report. So it's things like increasing face-to-face engagement, engaging with BAME communities and communities with smaller GP surgeries. The one recommendation in the report that is collaborative is something that I've probably said at this meeting multiple times, which is how we can use this intelligence to start to make actual changes within primary care in particular, but also secondary care. I'm happy to say that we're finally doing this, thanks to Neha acting as the driving force. So one of the ways in which we're doing this is that I produced a 2-year review of the 3 main themes that we consistently see popping up as negative. So this is around staff and their customer service, as we're calling it, access issues and administration issues. So booking appointments, waiting times, things like that. What this 2-year review shows is that issues with staff is largely correlated with the pandemic. While the other 2 may have been exacerbated by the pandemic, they are long-standing issues that need more focus. So I'll continue to work with Neha, and Neha's taking it to the next Borough Executive Committee meeting, and I think we'll have some really good discussion around that as to how we can take those findings forward. The second way in which we're trying to improve our influence and impact is I'm now speaking directly to practice managers before we publish the report, to gain their feedback, but also to hear what their point of view is going forward, what we need to do. And this is the first time around that we did that for quite some time, and we got some really good feedback from practice managers. A few managers showing their gratitude, other managers suggesting areas in which we could expand our patient experience feedback form, and then one practice manager in particular providing quite a comprehensive outline as to what their scores were in our report and how they plan to improve them. So that was really nice to see, and hopefully that can build on these relationships that have kind of fallen by the wayside during the pandemic. So that's our patient experience program. Moving on to our enter and view program, we've just completed 3 enter and view reports and visits to mental health hospitals, one of them being Colette House, and this will feed into the wider work that's going on with the review of Colette House. We'll work very closely with Ealing Council and Kerry to push this forward, and it's being taken to the next scrutiny panel. Now that those are completed, we're also in talks with the London North West Trust to understand how we could use our enter and view program to support their improvement strategy for maternity services. So this will be focusing on Northwick Park, but also any maternity services that are available in Ealing as well. Our research program, and it was included in the documents for this meeting, we've published our Integration Index project, which was a project commissioned by the NHS Improvement Team to understand how integrated care services are supporting particular character profiles, and using this as a methodology going forward to understand integrated care on a more national scale. So we've produced quite a comprehensive piece of work on how women with multiple long-term health conditions, including a heart condition, are being supported by services in an integrated way. And it's quite a long report, but some really good information in there. And hopefully we can take this forward to some meetings to understand how that intelligence can be used. We then have our disabilities project, which is due to be published or completed rather at the end of this month and then presented on. I spoke to Kerry earlier today, and there are some really interesting findings in there that hopefully we can work together on to create some actions around those findings. And then next month, we'll be producing our housebound reports in a similar vein to the disabilities project. So carrying that forward and understanding what follow-on actions we can take from our findings. And then finally, just to wrap up our engagement work, we recently held a cancer screening awareness engagement event with the Northwest London engagement team. And we're hoping to conduct another one soon, which focuses on heart health. And that's it.
Thank you. I say some really in-depth work, and the kind of the one on the integrated care is particularly detailed. So thank you for sharing it with us. It's really helpful. Perhaps if we just take, I don't know, Fabio, whether you wanted to declare your employment before we start talking about feedback on GP surgeries.
Oh yes, yeah. So I'm a GP, not in Ealing, but in Hounslow. So, but yes, a slight invested interest in talking about GPs. But can I ask a question, or as I'm talking already, or should I wait?
Please do. I was going to ask Nehal if she and Vijay.
Oh no, fine. I'll wait.
Nehal, Vijay, did you want to respond to anything on the patient experience report specifically, and then we can move on to Fabio and other items?
Yeah, from my perspective, I think it's always a very useful report and makes you think. And we look at these reports on a monthly basis. We are taking, so this is a snapshot of one quarter. So what I asked Matt to do was look over a period of time and what the trends were over COVID. And I think it's important that we reflect on the changing ways that primary care has had to see patients and very quickly adapt to new technologies themselves. And there is a lot of learning that's coming through from different parts of the country and Northwest London and London about how they're capitalizing and using these technologies. Technologies aren't, these digital technologies, and digital first isn't going away anytime soon. So, but it's important that we don't lose sight of the fact that other patients that aren't able to use those technologies aren't compromised in their ability to access primary care. So we're really keen to do a very detailed piece of work, especially over the winter period. And we had a conversation with some of our clinical leadership across the borough and GPs across the borough this afternoon with some very clear actions of what we're looking to take forward over the winter period. So I'm hoping with the report, so we've got bits of information that we can triangulate now. We've got the Healthwatch reports over a period of time, the more detailed, in-depth analysis quarter by quarter as well, and what that says. The feedback that we get as well from other patient engagement activities, what our GPs are telling us about how busy and how they are coping with this new way of working, but also the demands of recovery post-COVID as well, workforce issues. So what we're looking to do is triangulate all of this and come up with a sensible action plan of things we can do from a short-term perspective, medium-term and longer-term to improve GP access. But this report not only brings out access, but also about customer services and staffing, comments about how their experience has been when they have contacted a GP practice. So I think it's going to be a very rounded piece of work to try and look at all sorts of things and a very detailed but what's the word I'm trying to find? It's multifactorial, I think is the word, action plan to try and address some of the things that are coming through on here.
Okay, thanks, Vijay. I don't know if there's anything you wanted to add on.
No, I think Nao's covered all the key areas. I think it's just one thing just to highlight is clearly with the COVID pandemic, in terms of these quarterly reviews, it's the number of feedbacks that are coming through. These are small numbers, which clearly then have a different interpretation and impact in terms of what they are actually saying. But certainly the 2-year collated review, which Matt has now produced, will give us some good insight in terms of what we need to do locally in terms of primary care experience, particularly in reference to access and customer service and satisfaction.
Thanks, Fabio, and apologies. I always have it in my head you're an Ealing GP as opposed to a GP in Ealing. So apologies for
that's all right.
Kind of getting that a little bit muddled.
That's fine. So I had a couple of questions on the first paper. I think, Matt, I think they're all really interesting. I think they're really great pieces of work. I think because obviously you spoke about how this gets fed back in terms of sort of general practice and etc. But obviously you also survey dentists and opticians, and I just wonder what's the mechanism of feeding back any recommendations? Because I know sort of dental access is also what is an issue as well. I was wondering what forums are used to feed that information back to other sort of health providers away from sort of hospital and GPs. Just on, obviously you covered quite a large number of practices in terms of survey, but there were some practices that had no sort of surveying at all done to them. And I was just wondering what the reason for that was, and whether in the next quarter, are you going to be concentrating on getting some feedback from the ones that weren't, that didn't have any sort of responses from? There were two on that paper. Do you want to maybe answer those first, and just one other question on the other one?
Yeah, of course. We are working quite hard now to, I guess, strengthen those relationships with dental services, pharmacies, opticians, and other service categories to start to work with them like we work with hospitals in particular and GP services as well. The relationships definitely aren't as strong there. And I think particularly because it is often somewhat of an afterthought. I think usually we get somebody's feedback on a GP service and then say, oh, and also have you spoken to, or have you accessed dental services or pharmacies or something like that? So the focus is definitely on GP services, and that's maybe led by the negative feedback that we receive. So that's definitely an area of improvement. And then, as BJ touched on earlier, it's a bit of a balancing act between that there are targets to hit, as well as trying to be as representative as possible with the report. Now, this is going to be slightly easier as we move out of the pandemic, but during the pandemic, it was really difficult to get that representative sample. So now we've got a lot of work ahead of us to speak to people at smaller GP surgeries, get the views of people from BAME backgrounds. So there's a lot of work to be done. And I think this is why we're exercising caution when we use this local intelligence to start feeding into bigger picture stuff that Neha is heading up.
Great, thank you. My only other question was on the other, the paper on women and the ICP. It's just, it talks about in sort of the conclusion part.
Sorry, just pause a second. So I think following on from that, Simon just put something in the chat about the focus on Ealing practices. I think, Matt, if you, as it touches on what you were just saying, do you want to just kind of elaborate on how that kind of expansion of getting that more representative sample is going to happen?
Yeah, sorry, I'm just thinking now. I'm stuck over 50 respondents. Oh, this one. Jargon. Yeah, I mean, it's exactly what the issue is with the report, I think, and what I'm trying to push forward as the operations manager of Healthwatch. But it's a difficult ask. It is a difficult ask, and we're trying to think of ways that we can strike the balance between getting as many bits of feedback as possible from people and ensuring that it's representative. This may be a discussion where we might have to reduce the target in order to get a more representative sample. But it's definitely an area that needs further improvement.
Simon, were you?
So I suppose the question is there anything else that others can do to help in terms of getting a more representation? I'm not quite sure how the study was organised, but is there something the practices can help try and solicit feedback from within their areas, or are there things the council can do to help, or other groups? But given that we had the big focus as part of COVID and the inequalities agenda now, how that affected disproportionately BAME communities and Asian communities from Southall, I think there's only 3 responses from Southall. So clearly we need to find a way of getting better feedback, I suppose, and it's not just down to Healthwatch. I suppose the question for me is and maybe you don't know now, but maybe it's something to think about. Is there something that others have asked that can help with it? And even if that's within the hospital, asking about the GP experience rather than trying to catch them in the GP, I'm happy to help if there are ways we can help.
Yeah, sorry, Simon, I understand the question now. The work that we've been doing throughout the pandemic has largely been off our own back. And I think prior to this and going forward, we need our patient experience report to be as collaborative as possible. So as you quite rightly say, if we're able to get support from other stakeholders, whether that's just access to other services, so our patient experience officers can speak to members of the public there, or any promotional work they can do, then that would be a massive benefit to the report and the inequalities agenda in particular, I think.
Right, thanks. Sorry, apologies, Fabio. Just
that's right,
to cover the same ground at the same time. But you had a question on the integrated.
Yeah, so it was just that I guess the thing coming through from it was about the sort of difficulties with, in terms of holistic care, and in terms of, obviously, I guess the whole thing of the integrated care network is trying to bring everything together and a more holistic approach. I guess in terms of this particular sort of group of people, looking at women with multiple health issues, is there a particular stream of work within the ICP looking at this particular group, and in terms of following through their experience, to sort of, I guess, in a year or 2 years' time, looking back at this piece of work that you've done to then compare, what's happened. I was just wondering in terms of, because obviously the outcomes, obviously there's a great piece of work, and I'm just wondering how this tallies in with the streams of work that are going on within the ICP.
Yeah, and I think those discussions haven't quite started yet, and I was hoping that at the next ICP meeting that I'd be able to get this on the agenda to have that discussion, because I think it can be a platform for a wider piece of work, as you say, focusing on this group in particular, but other cohorts that will need this access to holistic care. I'm not actually sure of what particular streams it can feed into or where it fits, but if I'm able to present on the report and then have some subsequent discussions with other partners, then I think that would be really useful.
Thanks. Are there any other questions or comments for Matt? No. Matt, again, thank you so much. I mean, if the council can support in promoting the surveys, we will do so. But obviously, I think health colleagues have a vested interest in getting a wide and representative sample for their own benefit. So I'm sure they will be able to kind of consider their own interest in helping you get that kind of representative sample, as Simon has said. So thank you very much.
Thank you.
So we move on. We have a COVID update from Anna, our Director of Public Health, and I think you have a presentation for us.
Yeah, thank you, Chair. Good evening, everybody. I think Judith is going to be very kindly sharing my presentation this evening. So thank you, Chair. So there's a lot of detail on the slides this evening. I think it's really helpful to share them, but I'm just going to talk through some highlights from them, and then we'll share. They're already published on the website. So just going to talk through the kind of usual aspects in terms of national and local situation. Going to touch on education settings because that's been a change since we last met. Vaccinations, just an overview, and then Neha's going to talk us through a different slide set. Testing, there's been a few changes, and then contact tracing care homes. So thanks, Judith. Next slide. So just wanted to touch on the current situation nationally. So you can see very visually from the map on the right hand side, the darker and the blue and the darker areas have the higher rates. So you can see London's one of the lowest regions in the countries at the moment. Midlands, Northwest, Scotland have had much higher rates over the last couple of months over the summer. And London's been at the lower end. That is starting to even out a little bit. Just from the little graphs on the bottom, I think the one to focus on is the one on the left. Over the summer, where this shows how many people have tested positive. Over the summer, it's been fluctuating around nationally and has been higher at an England level than in London. We are starting to see those rates go up again over the last couple of weeks. Next one, please. So just touching on the autumn and winter plan that the government published in mid-September, this is really just to outline the COVID response over the next few months. Plan A is essentially what we're doing now. So carrying on with the big push on vaccines, that includes the newer programs like those for age 12 to 15, booster programs over the autumn and winter, and also what's called the evergreen offer. So really trying to encourage anybody that hasn't had their first or second dose to have them at any time. Carrying on with the testing as it is currently. One thing just to flag here, possibly from a kind of future concern and inequalities point of view, is that the rapid tests for people without symptoms that we try and encourage residents to do twice a week, the government's saying they're currently free over autumn and winter, but that might change into next year, and possibly even the PCR tests that are used to test for people with symptoms. So it's just something for this board to keep an eye on. And then plan B would come in if data suggests that the NHS is becoming more overwhelmed. That's not currently the case at the moment, but with other winter pressures, there is a possibility that the NHS may become busier over winter. The main measure under this is actually in terms of people working from home, really encouraging people to do that. As you've got quite a lot of people across the country who are now vaccinated, that additional benefit from reducing social contact by working at home, the scientific advisors think might make quite a big difference over this winter. There's also plans to maybe bring in COVID certification for vaccinations or testing for things like nightclubs, big events, maybe bringing back in mandated face coverings. I think what's missing from this plan at the moment is what happens if that's not enough. Obviously, the vaccinations give very, very heavy protection, but in London, the vaccination rates generally are lower than the rest of the country. There's still inequalities in that vaccination uptake, and obviously just a situation for us to keep a watchful eye on. Next one, please, Judith. So in Ealing at the moment, you'll see over the right-hand side of the graph that the rates over summer have been stable-ish. They haven't been what I would call low. So you've still got about 800 or 900 residents testing positive a week. So that compares to pretty much where we were in, say, February. So it still feels like it's stable but not low. And we are higher than London but lower than England because other regions are much higher than us. One important thing to point out in the last week, the rates in the secondary school age children have really jumped up. So we're now seeing a third of our total cases are in that age 10 to 19 group. We have got low rates among older adult groups, but it's worth just being aware of that new dimension. Inequalities, the patterns really changed over the summer. We're now seeing areas like Ealing, Acton Towns and Greenford having the highest rates. Southall is one of the lowest rates at the moment, but that does change around at the moment. Next one, please. Deaths, again, you'll see from the bottom right-hand side of the graph, the numbers of people unfortunately dying with COVID each week, fortunately are very low at the moment, but again, they're not zero. So we've had almost 900 people die so far out of our residents. The death rate is, however, similar to England and London. And so again, it's something for us just to keep an eye on those measures. Next one. So in terms of outbreaks, you'll just see very briefly from this table, we've got very, very few outbreaks in things like care homes, workplaces, etc. The main source at the moment is outbreaks in schools. Just to give assurance, so none of those are very substantial, none of them are serious. We're not seeing young people in hospital, etc. But then we have got a number of very small outbreaks in a large number of schools. Next, please. So this one I just wanted to focus on. Obviously, schools have returned in the autumn. The guidance for schools and the context that schools are being asked to work in has really changed since last June when we last met. Department of Health have set some thresholds for when schools need to take extra action. So at the moment, there are no major COVID measures in place. So things like bubbles in schools, social distancing, masks have all stopped now into this autumn term. Schools are still being advised to take sensible actions in terms of things like ventilation, etc. But on the whole, those other measures from last term have gone. So if a school has 5 pupils or staff who are known to have mixed closely, testing positive for COVID, then they meet the first threshold. And that threshold is obviously lower for special schools. Or if they are starting to see, unfortunately, anybody ending up in hospital with COVID, that will trigger extra action. And at that point, the school has conversations with Public Health England and ourselves about additional measures they can put in. Those initial ones are things like improving ventilation even more, some enhanced cleaning, having a think whether some activities like assemblies can take place outdoors, which obviously becomes harder over the winter months. Thinking about whether to do things like open days in a different way. and really trying to encourage pupils to carry on with the twice weekly home testing, even if they don't have symptoms. Bubbles and things like that at the kind of higher end may be brought in later in the autumn if schools have larger outbreaks, but we're not there yet on any of our schools. Next, please, Judith. And so in terms of our local position, we've had just over 400 cases reported since September. We've already mentioned we've had 35 outbreaks in schools, and we've had 17 who have met that Department for Education threshold, so are having some sort of enhanced measures, although nothing major at the moment, and we continue to monitor that really closely and work with schools to support them around key messaging. Next, please. So just in terms of vaccinations, really briefly, Neha will obviously go through this in more detail. We're now on to over 200,000 people who've had their first doses. Inequalities are really similar since we last spoke. So rates are lower in places like Acton and Northolt, parts of Southall. Uptake is lowest in more deprived communities among younger men. And there are some big ethnic disparities there. So people who are from Black Caribbean or other Black mixed ethnic groups having much lower uptake, some traveller communities. We are doing an awful lot of work in the background around ongoing support for communities in terms of vaccine confidence and vaccine accessibility. We're particularly doing some work with a range of colleagues from different organisations across Ealing in terms of homelessness and rough sleepers. I think the next stage for us is trying to do more of a push on people who live in houses of multiple occupation. That's a group that's very hard to reach in direct ways, but we've got a subgroup there that focuses on those inclusion health groups. We've been doing a lot of work in the last few weeks, has been very intensive around the age 12 to 15 programme for vaccinations that's being coordinated across North West London. Villiers School was the first in London to start the vaccinations. It was really great uptake there, really great response from the families in the schools. We had over 70% uptake, which was amazing. And as we go forward with the schools, we've had 3 so far that have had their vaccinations. We are going to keep analysing that regularly to support decision making around whether we do specific work with communities to support uptake of that. Next one, please, Judith. So just a quick update on testing. The testing for people who have got symptoms and want a PCR test has stayed the same. We've still got the local testing sites, 3 dotted around the borough for walk-ins and 1 at Gurnell for drive-through. People can still access home testing kits online. Next one. The context that changed a lot more since we last met in June was around regular testing for people without symptoms. So just to remind you, about a third of people with COVID don't have symptoms or might have very mild symptoms. And so we really try and encourage people to do tests twice a week. Since July, we've been trying to do much more of a targeted approach to this. So we've got 17 pharmacies dotted around the borough where people can get help with doing their tests. We've also been doing work with faith organisations who have got links now with those local pharmacies and can carry out that assisted testing on certain days. We've also been distributing home testing kits through a number of hostels and the local food bank. And we've been doing some pop-up test kit distribution at things like festivals and large faith gatherings. So we're currently exploring what that next phase looks like. We've had that programme nationally is extended now till the end of December. So it gives us time to really carry on, build on that good experience, had really, really positive feedback from a number of those community groups and really see if there's other groups and organisations that we want to link in with there. Next slide, please. And just briefly on contact tracing, that service is still going really well. We've managed to recruit to more posts there and do extra training. Over the summer, we've been doing something called Local 24, which just means that the central NHS contact tracing team makes calls for the first 24 hours after someone's tested positive. And then if they can't reach them, they pass them back to the local team. We're trying actively to move to the next stage of that. where the NHS service only calls them for the first 4 hours, and then we get much more, many more of our local cases and really get the benefits from that local team. But over summer, just from a capacity point of view, nationally, it made sense that NHS was supporting us with that. And to date, the team's called over 10,000 residents and has really good success rates. Next one. And just finishing off the last couple of slides, care homes, just to say, we've got one small care home that's been closed to new admissions at the moment following an outbreak that we're working with closely. I think the really good news from a care home setting is in terms of staff vaccinations. So a few months ago, government made it mandatory for all care home staff to be fully vaccinated by mid-November. We've had a massive push on that, and care homes and everyone has been really supportive of that. Obviously, our NHS colleagues doing a really big push there. We've now had 97% of care home staff having their first dose and 88% the second dose. And booster jabs have started for those staff as well. So that's great news. That's a much more positive position than we thought we'd be in, and is actually the highest first dose uptake in London, which is really a testament to everyone's hard work on that. And just to mention that there is a national consultation happening at the moment about extending that mandatory vaccination to other health and social care staff. And that for us would include things like home care, which is a massive workforce. So something we just need to keep an eye on. And next one. Just finally, just 2 quick slides. These have got some links on as well, which are great if people want to look at afterwards. Just our key messages at the moment are mostly around vaccinations. So in terms of boosters, if anybody's a frontline health or social care worker, they're over 50 or they're an adult with a long-term health condition, they're eligible for a booster as long as it's been 6 months after their second dose. So people can book a line through that. The age 12 to 15 vaccinations we've already talked about. We're communicating with families that they will be contacted directly from the school to let them know when the vaccinations will be given, and families obviously asked to give consent. And next one. Thanks. And here's just some links if people want to have a look at the guidance documents for age 12 to 15 vaccinations there for the schools, some more technical ones, but also some really good easy read resources for children and young people and for families, if anybody wants to share those. And also, obviously, we're going into the normal kind of winter flu season as well as COVID. So really important to support health and care workers to take up the flu vaccine as well as a COVID booster. That's all from me. Thank you.
Thanks, Anna. As ever, a very comprehensive report. I think there'd been a question from Roy from EarthGag on the care home staff vaccination, which I think you've covered. There was also on the home care sector. I don't know if you or Kerry's wanted to very briefly answer that one. I think you've got the numbers.
Yeah, I think that would be for Kerry if he's okay to come in.
Yeah, certainly. Thank you, Anna. Thank you, Chair. So the numbers in terms of the home care sector is currently 83% of people in the sector have had their first vaccine and 71% have had their second vaccine. And as Anna mentioned earlier, this is going to be a significant area of focus for us going forward.
Great. Thank you, Kerry. It's probably important to note those are still above the kind of Ealing average, so doing better than overall. Which is a good sign. I suppose Simon had also put in the chat about Ealing Hospital's inpatient numbers, which is really helpful. Thank you, Simon. Anna, do we have any other information about kind of hospitalisations across, well, I suppose Northwest London, given where the hospitals are, would be helpful just to understand what the numbers are meaning.
Yeah, thank you, Chair. I haven't got the exact numbers to hand, but just in terms of the patterns, we're not seeing particularly high hospitalisation rates across Northwest London and London. Again, they're not very low, and they have remained kind of quite stable over the summer. And that's being translated into those relatively low numbers of deaths as well. I think, and Simon might want to add into this, but the information I'm getting is that you are getting the group of very much older people with lots of vulnerabilities who might have been double vaccinated, but obviously have other vulnerabilities there. And then you've got just over half of people in hospitals in London unvaccinated, and definitely at that kind of lower end. However, the good sign is that because they're younger, they might actually be in hospital for much less time than we were seeing, say, back in the winter. So it's quite a different cohort of people now. But obviously, no, we don't want anyone to be in that situation. But yeah, it's something for us definitely, as we're seeing rates starting to rise, just to kind of keep an eye on. Although obviously a lot of those rates are in younger people who are much less likely to be in hospital.
Yeah,
thanks, Simon.
Yeah, I'll just reinforce what Anna said in terms of the type of presentations that we're seeing with the COVID, and I think what we've seen is since July really is a steady sort of position in terms of the 20 to 30 at Ealing, and at Northwick it's in the sort of the mid 50s to the 80s that it's ranged at. So not dissimilar proportions in terms of the number of beds occupied by COVID patients. The relevance for us is around winter and winter planning and resilience, because effectively it's taken at least 1.5 wards out at Ealing, and it takes 2 to 3 wards out at Northwick Park. So we always know winter's a challenge for us. So we've got COVID to contend with this winter. So I suppose I'm just flagging it is going to be a tough winter ahead, and the system working support in terms of discharges is important as well.
Okay, I think we've got Rashesh's update on winter plan coming up later.
Exactly.
So we will come back to winter in some detail. Fabio, you had a question.
Yeah, just 2 brief questions. One was on the second doses of the COVID jab. There's no, I was trying to scroll down the exact number. It was like 200, I think it was 13,000 first dose and only 133,000 second doses. It seemed like quite a big gap when I think nationally something like 89% first and 83% I think second doses. So it seems much wider in Ealing. And I was wondering, is that just because people received their first doses a lot later and therefore they haven't reached the threshold where they're getting it yet? Or is there a problem with people coming forward to get their second doses? And my second question is just on the boosters in care homes. I was just wondering, in terms of the how quickly that's going to be completed, and also are they getting their flu jabs at the same time?
Those are very good questions. Let's hand over to Nehal for the vaccination update then, and if Nehal you could try and cover off those, because I know there is a slide on kind of delivery of the booster program as well. So is that if that's okay, Fabio, we'll kind of take those as part of the next item. Nehal.
Sure. I'm just going to share my screen and the slides. Just bear with me. Okay, I'm hoping you can see my slides. Okay, so
you could just make them on slideshow mode so they're a bit bigger. Sorry, thank you. Perfect.
Right. Okay. So this is the position from the data that we have. We have so many sources of information. This is public health data as of the 4th of October. We pulled this data yesterday. And as you can see with the second doses, it really depends on when they had their first. And you can see from those populations that had their first doses earlier on, most of them have had their second doses as well. Sorry, I don't know what's going on there. Most of them, where it turns green, they've had their second doses as well. Where it's blue, it means they've only had one dose. So as you can see, as the age drops, so it's going to take time for those people to have their second doses. And the grey is where a patient, a resident hasn't had a dose at all. So the graphs on the right, the pictures on the right show the take-up rate by ward as well, of the first dose and the second dose. And you can see with the second dose, there are some areas that it's not caught up as well as we would have hoped. So we've had really good coverage of the first for a number of these, but the second dose has just dropped off a little bit. So we're doing work actively to try and pick that up. This shows some more of the demographic breakdown of dose 1 and 2 by sex, but also ethnicity at the bottom. And you can see, you know, that there isn't a sort of breakdown between 1 and 2 and take-up rates. It is just between ethnicity or between sex. It is just literally about catching up with that second dose. So I'm sure that will catch up soon. In terms of the key messages, so our autumn plan about what's going on with the vaccine program. So the 12 to 15-year-olds, we've already Anna just spoke about, and Villiers School was one of the first to go live, and the team were working really hard to try and get to all schools around Northwest London as soon as possible. So Villiers was the first one to go live. Some fantastic work that's happened, some learning to share right across everywhere, in fact, because the take-up rate was so high. So really proud of that work that the team have done, and you know, thanks to everybody that's been involved in that. The booster program has started, and a lot of patients are now starting to receive their invitations. And there'll be 2 sets of invitations. They could be contacted directly by their GP practice. Patients could be contacted directly by the GP practice, or they could be contacted by the national booking system and receive a text via that system to then book an appointment at one of the other sites and not necessarily their GP practice site. Just to note, they will only get their second dose 6 months after they'll only get their booster 6 months after their second dose. So not everybody will be eligible as yet, but those invites have started to go out. And 2 of our sites are live, and I'll talk about that in a moment. In addition, there are the immunosuppressed patients. So these are patients who, as part of their primary dose of vaccination, they're receiving their 3rd dose. We have our GP practices are proactively trying to engage and call these patients in for a 3rd dose into one of the settings that we have locally. And I'll show you the settings in a moment. And in parallel, practices, pharmacies, and everyone has started working on the flu vaccination program as well, and that's moving at speed. So the 3 sites that we have from a primary care perspective are the Dominion Centre, which has restarted. It restarted this weekend, just gone. Mattock Lane Pharmacy is operating out of St John's Church and is working with a number of our practices to deliver the vaccination for them. And Grand Union Village, which isn't actually live yet, but it will be very shortly in the next couple of weeks, I'm hoping. Pharmacy sites, we have, including the 9 existing sites, we have more vaccine pharmacy sites going live shortly. And they will be on the national booking system, but there are a number of sites that were live before that will be already available on the national booking system. And CP House, which is in the centre of Ealing, is being used as a base for the roving team, the Northwest London team, who are going out to schools and supporting some of the care home vaccination programme. But they are also have a walk-in service and on the national booking system for vaccination capacity, COVID vaccination capacity. That's additional capacity in Ealing, which is great news for us. And I was just talking about the roving vaccination team who are going into the schools, care homes, and will be supporting housebound vaccinations as well. This just shows a map of some of our sites around Ealing, and the ones in purple are sort of out of area. The ones in red are due to go live very shortly, and the ones in green are already live. And then the 3 blue stars are 3 PCN vaccination sites, our GP vaccination sites. So you can see quite a good level of coverage for patients to come to have vaccine. Right, so this slide is very busy, but what I was just trying to map here is to demonstrate and use a bit of communication tool. Sorry, there's a bit of echo. I'm not sure where that's coming from.
I think, Aisha, your microphone is unmuted. If you could just pop it on mute, I think that might help solve some of the echo.
Thank you. So our GPs, as you all know, work as primary care networks, so geographically located groups of GP practices. We have 8 in Ealing. So I've used those as geographical distinctions of where patients can get their vaccinations from these various cohorts. So the only two I would just pick up here, which is the immunosuppressed for Greenwell and NGP, which is Norfolk, Greenford and Perivale areas. There is capacity at CP House. And in addition, they've been working really closely with local pharmacy sites to make sure that they have capacity. So when the GPs can call these patients, they have somewhere close by to go and have their vaccination. So there is good coverage everywhere. And our care home vaccination program has started. This slide just starts to describe where we've got to with the flu vaccination program, because I think that was a question as well. It's really started really fast, and the take-up rate has been really good with the flu vaccination so far, but that we'll keep a close eye on that. So I was going to stop sharing there and happy to take any questions.
Great, thank you. I think that probably covers Fabio's questions. He's nodding, which is good. Are there any other questions for Neha on the vaccination program? No. Well, thank you, Neha. Not only for the presentation, but for all the hard work. I know speaking to you before the summer how much kind of effort was going in. So hopefully you had a bit of a break at some point in the team. But thank you very much for that. We move on to the winter health plan. And Rashesh, are you presenting this?
I think Kerry was going to.
Kerry.
And then
I'm just going to do a brief introduction, if that's okay, Chair. Rashesh has done the huge amount of work on this. Just to say that, as Simon mentioned earlier, we're expecting significant pressures this winter as we move into the winter months, and the absolute importance of working together as a system to get our winter plans in place is key to supporting the acute sector. Just wanted to set that out in terms of Rashesh's presentation. So over to you, Rashesh.
Thank you, Kerry. I think just wanted to kind of mention that it's been a teamwork with all system stakeholders, all our ICP partners, including our London Northwest colleagues, where we've actually managed to bring all the winter schemes plus our risks and everything together in a very short space of time. I think this year, due to all the changes that has happened across within the NHS and the move from individual CCGs to Northwest London CCGs and direction of travel to the ICS, the winter plan this year has been led mainly by London Northwest, but with support from individual boroughs, that is Ealing, Harrow and Brent. And with London Northwest leading, we were tasked to kind of bring together our local plans. As an ICP, we all gathered together, including our primary care, mental health colleagues, community colleagues, and other system stakeholders, to kind of bring plan together. And we've looked at what the gaps are, what kind of key risks are for us, specifically that Simon has already alluded to around the demand and capacity issues. One of the key things, because of the COVID and uncertainty around it, is the workforce, if it cannot be sustained. And of course, if elective care run rate negatively impacts by winter, causing cancellations, and then the pandemic response, how we kind of take things forward. Also, one of the key things is the out of hospital capacity is quite crucial in order to support the winter plan and our local hospital trusts. What we've done is we have within the current submission, all different schemes are there across Northwest London, but specifically for the purpose of today's meeting, I've kind of just pulled out headlines around our Ealing particular schemes, which relate from acute UTCs, which is around same-day emergency care, admission avoidance, the alcohol care team at Ealing Hospital supporting patients to reduce alcohol-related harms, the mental health schemes around site liaison, as well as the safe place of safety. We've got the primary care schemes, which we've all looked into around the extended access hubs, as well as the Ealing Standard and the vaccination program that Anna and Neha has kindly kind of spoken about. We've got our community schemes, which is all around MDT supports, the better use of IT technology, discharge hubs that are key, which work very closely with our Northwest London colleagues, are a communication between trusts, social workers, as well as our community services is quite key to ensure that discharges are happening rapidly and quickly to support the patients to be moving into a safe placement as soon as possible, whether it is through packages of care or a step-down bed. We're also talking about increasing our capacity for social services around 7-day service, work with our care home cell, as well as the Better Care Fund, and joint commissioning is also going to support the different work streams around winter. So that it's a quick brief in a nutshell, the plan that we've got, but I'm happy to take any questions or if anybody wants to chip in anything else. The key important thing before anybody says any questions is the deadline for submission as a system for London Northwest system was the 30th of September for us to kind of submit the to NHS England, and we have done that via the Northwest London CCTs and ICS, and now we are waiting to hear from them about all the schemes that we have put forward, whether we are going to get any sort of funding for winter pressures, and we take it from there. But in the meantime, as an ICP, we are already starting to pull a bit more detailed winter bids to seek any funding that we can pull together for supporting the London Northwest system.
Thank you. A whistle-stop tour of a very big plan. So thank you for denting that down. I don't know if members of the board had any questions. Fabio.
My question was, obviously you mentioned obviously that it was submitted a few weeks ago, and obviously you're waiting to hear back. But I guess in terms of then implementing it, because obviously a lot of it, if you read it, involves some of the items, bolstering, numbers of staff in terms of, for example, site liaison, or bolstering the number of hours that services are operating for. I guess if the green light is given for this plan, what's the time scale of it actually getting up and running? I guess it will be different for the different schemes, but what's the objective of how quickly that could be implemented? Because, for example, in terms of recruitment, I know that can obviously be very difficult, and obviously the winter is fast approaching. I was just wondering what the timescales were in terms of you don't go through each item, but in general, what the timescale of actually getting this up and running.
So, thank you, Councillor Fabio. I think that's a very good question. Year on year, we have dealt with these sort of issues where NHS England have actually provided us, if they've provided us with the funding, it's generally within a very short deadline that we have to start getting resources. Either it is as an interim staff for a short couple of weeks or for 2-3 months to cover the winter period and to support that particular aspect, or we move staff from one area to another to make sure that whether joint working can be possible to support that pieces of work, whether it is through additional 7-day working from 5, or it is whether having extra step down beds to kind of, we already started sourcing, we've got everything ready. It's all just getting an answer and a response. Yes, we've given you the money. Can you please start implementing? If that is the case, what we've already planned is whether if there is a delay. So instead of say from 1st of November, it may be from 1st of December that we may be able to get that funding. Then we already will have plans. So we make our plan in terms of funding to be utilized week on week. So that makes it very easier for us to kind of go out in the market, get the recruitment of staff, and then we start pulling things together.
Great. Kerry, you've got your hand up, but Chris, I think you briefly had your hand up. Did you want to add something first?
Yes, I'm happy to, and apologies that I'm not on camera. I was just going to make the point that a number of these schemes we will be planning for anyway, and there will be a certain number that. So, for instance, psychiatric liaison we've done every year for the last few years, and I think I'd be expecting us to implement this. And the question around bidding for funds, hopefully, will be successful, but otherwise we'll be seeking other internal prioritization to make sure that we're able to meet the winter demand.
Great, thanks. And Kerry.
Just to provide Councillor Conti the assurance that we've been doing a lot of the preparation work
for implementation prior to the plans being developed. So just to agree with what Rashesh and Chris have said. Thank you.
Great, and I think Simon has put in the chat that from the trust perspective, they're anticipating the majority of the funding will flow, which is an optimistic point, Simon. And
yeah, it is, but a bit like Chris said, if it doesn't flow, we will have to look for contingencies and mitigations to make it happen. I think from a trust perspective, these are the things we act de minimis that we believe we're going to have to put in place. So we'll have to move resources around as necessary, but we're not waiting. Certainly on recruitment of key staff in key positions for formal approval process, although we would anticipate that being sorted in the next couple of weeks. We're just getting on with it. And just a special thanks to Rashesh and to Ealing. I think in terms of the 3 boroughs we work with, Ealing led the way in terms of kicking off the winter planning process, and certainly we've had good support from partners as part of that planning process, as we have done in terms of improving the discharge responsiveness across all aspects. So thank you.
Great, thank you. There were a couple of questions from members of the public on winter plan. One from on mental health, and I don't know, Chris, I think you were going to pick this one up, just around mental health beds and where the social worker would be working.
Absolutely. I think this was a question from Dr. Lowy, and her question was commenting that Ealing doesn't, or the questioner said there are no adult mental health beds in Ealing other than forensic beds, and where would the social worker be working? So I would just respond to that, and I'd say it's correct that there aren't any general adult mental health beds in Ealing currently. Just for context, we have 246 specialist forensic beds on the Ealing Hospital site. We've got 38 older adults and dementia beds for the 3 boroughs based in Ealing, on the Ealing Hospital site. And we also have 17 beds in the Amadeus Recovery and Crisis House in Ealing, which provide an acute mental health inpatient option. And that's delivered in partnership with Rethink. We've also got the crisis teams and recently opened the safe space with Mind at the Lido Centre for Adults in Crisis. To respond specifically to Clara's question, for many years the Trust has operated our general adult bed base across the 3 boroughs, Ealing at St Bernard's, Hounslow at Lakeside, West Middlesex, and at Charing Cross in Hammersmith and Fulham. And this flexibility has helped us not have to use out-of-area placements for many years, even when wards have been closed to admissions due to COVID outbreaks. And actually often we're able to support neighbouring organisations with capacity. During COVID, when there were staffing pressures and infection control concerns, we did take the decision temporarily to suspend our beds in the least fit for purpose accommodation that we have, and that's in the pre-Victorian buildings on the Ealing Hospital site. And we've re-provided a proportion of those beds in more modern facilities at West Middlesex. We're still currently considering our options regarding the reopening of the beds, and any permanent changes will follow any public consultation. Regarding a social worker that's referenced in the winter plan, because this is an Ealing plan, this will work with Ealing patients wherever they're admitted, and we've got equivalent staff based across all of our sites. They may also work at Ealing headquarters or at Percival House. Thanks, Chris.
Do we have a timeline on that decision that would go to public consultation, or is it still?
It's still in a kind of options appraisal stage internally, and certainly we'll be keen to share further thinking at the earliest possible opportunity.
Thanks. I suppose it might be worth taking another question around discharge to assess at this point as well from Roy. Roy, I don't know if you wanted to ask your question about that, because it forms part of the winter plan from the local authority perspective.
Yes, good idea. Thank you. Yeah, it's just a short question about what does the board think about would be the main differences if the government's discharge to assess clause in the new health and care bill is adopted, and that would replace the present assess before discharge arrangements. And really, the issue is, will patients and carers' interests be properly taken into account? And so I'd like to hear what, I know it hasn't happened yet, but it is quite likely to happen. So I'd be interested to know what people think would be the implications.
Yeah, and I think it's it's what we've been doing for some time now through COVID. So Kerry, did you want to pick up from the council side and Chris from the NHS side?
Thank you, Chair. Thank you for the question, Roy. Absolutely, we're working very closely with our NHS partners to ensure that patients are central to the discharge to assess process. We have regular meetings and regular engagement with the discharge coordinators who are leading the discharge process, and I'm due to meet with colleagues from Simon's perspective, from a senior management perspective, to review the process to ensure that we're keeping patient at the centre of the process, but also ensuring that councils and community services needs are met within the process.
And I'm happy to come in from a health perspective. I mean, I guess from our perspective, the purpose of this is really to try to reduce the time that patients are in hospital unnecessarily once their medical treatment is finished, because hospitalization can lead to deconditioning and the risk of hospital infection, etc. And also it blocks a bed that another patient who needs medical treatment might require. And actually, we've been following a similar approach for quite some time, even pre-COVID. Northwest London was pursuing a model of discharge to assess, or home first, as it's sometimes called. And as Kerry has said, we're working really hard across health and care to make sure that we're able to assess and address patients' needs when they get home after discharge. And having looked at what the bill says, I don't think it changes legal obligations on us to meet people's needs, either from a health or a Care Act perspective. And just to answer Roy's specific question about patients and carers, the views of patients and carers and their consent is absolutely essential when care planning. And it's extremely unusual for us not to reach agreement about a care plan for discharge. And we'd really welcome any general feedback about the pathways if people wish to contact me.
Thanks. Rashesh, do you wanted to add something?
Yes, Chair, I just wanted to kind of give further assurance to Roy that discharge to assess has even been more integrated than what it was before. It's not only just with our Ealing borough, but also with our Northwest London colleagues. So the cross-border issues that were previously there are all trying to be kind of, smoothened. So we are able to kind of work more jointly, more working in integration and in matrix to ensure that the patient is at the heart of receiving the care when they require and more swiftly. So there is a constant dialogue between all the various teams on a regular basis, and come winter will start, there are going to be regular weekly, twice weekly calls to look at those patients who are actually either stuck, where they need any support, and how systems can move them together out to appropriate placement.
Thanks. Is there any other comments then on the winter plan? No. Again, thank you, Simon, for your comments about the council's work. It's very much appreciated and echoed, I think, by all. And thank you, everyone, for your input into the plan and the huge amount of planning that goes into it and the preparation and the commitment, I think, as well, to deliver it, regardless of whether we get the exact figure or not. So thank you very much. Anna, I think you're giving us an update on the Better Care Fund next.
I think that's Rashesh. Chair.
I keep seeing the wrong names on the tops of documents. Apologies. Rashesh.
Yeah, so just with the Better Care Fund, give you a big background that last year, because of the pandemic, the guidance for Better Care Fund had not been published, and it was rolled on straight into 21-22. So we kind of took a paper jointly between CCG and local authority to the cabinet to seek extension, as is with the caveat of once the guidance is going to be published, we would take things further and review the Section 75 schedules and the BCF together. And the cabinet agreed to that and gave a 2-year extension on the 31st of March 2021. And if it is okay, I will share the recent timelines with everybody out here, just so that the board is aware. The BCF planning requirements have just been published last week. We've managed to get the templates and the further technical guidance on the 1st of October. And we are meeting with our council colleagues on Thursday to kind of look at how we can shape things together and work together to make sure these submissions are made in time, and also seek sign-off from the Health and Wellbeing Board. And these are the times that we've got. We've already started working around our Section 75 agreements and schedules, which we've got timelines to submit by the 31st of January 2022. Therefore, just to make a note of these timelines, and we are happy to kind of take things forward. There's slight changes within the metrics which have come through, which we are still kind of looking at all the details. The change is that there's going to be a 5.3% uplift from CCGs on the minimum spend, which has already been agreed. And we are working with our finance colleagues to take things forward and putting the plans and submissions together. Open to any questions.
Great, thank you. If you don't mind just stopping sharing so I can see everyone.
Sorry.
That's quite all right. Thanks for the update. Any particular questions on that? I think the only question is how that fits with our timetable, but I'm sure we can work on that offline and when we need to meet to sign off the plan. Judith.
Yeah, thanks. We quite often just bring it to you out of normal sequence of Health and Wellbeing Board, so we'll do that again this time. Thank you.
Yeah.
Great, thank you. Integrated care partnership. I'm not going to guess who's delivering this one now, since I've got it all wrong all evening. But whoever wants to comment on the ICP, Chris.
Chair, I think it's me. And apologies again that I'm not on camera. I've got caught and I've found the quietest place that I can near St Mary's Hospital in Paddington Basin. So apologies for any background noise. I'm aware that the slides have been shared, so I'm just going to draw a few highlights from this. The Ealing Integrated Care Partnership has been forming itself over the last few months, and we've reported to the Health and Wellbeing Board previously that we would keep this board updated as to the activities of the ICP. And in order to do that this time, we've shared this pack, which is largely based on a pack that was created for a meeting that we recently had with the North West London ICS for a meeting called a system oversight meeting, where they wished to understand the work of Ealing Integrated Care Partnership. So I think this board is aware of the partners locally that are party to the Integrated Care Partnership, and we've previously described the way we are starting to organize ourselves with a board reporting into this board and our other organizational boards, a small sort of executive team, which we call the Operational Delivery Group, and a number of work streams below that, which are listed in the pack based on the consensus of the Operational Delivery Group and the board about areas of focus that would benefit from partnership working, and areas of need within Ealing. I won't go through each of the headlines, but just to give an example, one of those areas is around urgent and emergency care and system resilience, and it was that work stream that led to the conversations between the local authority, community, and London North West Healthcare that generated some of the work that Rashesh has presented today. We, across North West London, have found considerable consensus across all of the boroughs around areas that are priorities for all of us in the system. And they, as you'd expect, will be translated to have a very local flavour. So one of those is around our work on reducing inequalities and our taking a population health approach. And there are a number of examples listed in the slide pack that describe some of the work in response to COVID that we've done together as a partnership that we hope will give an example of how we can do other future working, hopefully less related to COVID in the future. We also were tasked with setting up a post-COVID service, and I've shared some information around. It's a slightly complicated diagram, but I suppose the key to it is the essential collaboration between primary care, the acute trust, which is running a post-COVID assessment clinic, a long COVID clinic, and a need to have pathways into a whole range of community services for rehabilitation and psychological support for individuals who develop that syndrome. A lot of our work is around enabling our teams to work together at a neighborhood level, so kind of at a ward or PCN level. And Ealing was in a good place to start this work, both through the Ealing standard, which the board has heard about before, in the way that primary care is contracted, but also in the way that now both the Ealing Community Partners community contract and our mental health services are organised. And you can see that we have met as a system recently in what was called a primary care summit with acute trust colleagues, local authority colleagues, and a huge attendance from primary care to come up with ideas about how we can work better to improve how we deal proactively with care for people with long-term conditions, and also respond to people with reactive care needs better. Some of the ideas that have been generated from that summit are described, but one of the key things which we've been doing is actually getting our teams to know each other, so that, you know, to speak, for example, for my services in Acton, making sure that the district nurses in Acton Health Centre know that there is a community mental health team at Avenue House 200 yards away, and that they're also 200 yards from the Sycamore Lodge memory clinic, etc., so that they can act, and that not only do they know that they're there, but they've got each other's numbers and email addresses and can start to explore joint working. So there's a lot of work now starting on the back of those introductions. We've described some priorities around diabetes care, and also are increasingly looking to level up our services, looking at the performance of different practices and of the different PCNs, to make sure that we are all achieving what the best PCNs are achieving for certain key metrics. And the ones that are highlighted here show, for instance, around undertaking physical health checks for people with mental health conditions. 5 of the 8 PCNs in Ealing are above average compared with their Northwest London peers. So what can we do together to try and make the remaining PCNs achieve at least that average? I guess I've also highlighted some of the work that's going on in mental health, but that again focuses on moving our care to hopefully be better linked with primary care and better spread across the primary care networks. We also spent a lot of the conversation talking about how we are trying to improve the health care that's provided in care homes, and to understand the system perspective of the care home market and the quality of care that's health and social care, I should say, that's provided in care homes, and looking through our local care home cell at a dashboard of data that supports a kind of shared understanding of that. That was one of the key things that was discussed on our first meeting this morning of a local integrated care partnership quality group, which is not quite looking at the individual performance of any of us as providers, but looking at our combined the combined quality of the services and pathways that we provide, really with an improvement focus. So where we find ourselves with areas for improvement, how we can work together. So this was really a summary of the the pack. And I guess a question really to us all and to this board about, or really an invitation for the Health and Wellbeing Board to think about how you would like to receive further information from us, and also how you would like, or what areas you would like us to report back to you in future meetings.
Okay, thanks, Chris. And I'm very glad to have summaries of very dense slides rather than trying to go through them all. So please do kind of keep joining in noisy, busy locations. That's great. So it is a comprehensive thing. I don't think we want to kind of go through taking questions on all the different bits, but the question Chris asks is a good one. Councillor Shaw.
Yeah, thanks, Chair. Sorry, I'm having problems getting my, there we go, I think my camera's on. But I'm now sitting in the way of the light, sorry about that. Yes, thanks very much for that, Chris. As sort of, I am just subbing on this board, but coming to it, I'm a little unclear just quite what the ICPs are. Listening to your introduction and summary, Chris, it sounds like it's sort of North West London partners getting together. You're trying to improve and make more efficient pathways for people, but it sounds very much like you're at the early stages. You were talking a lot about how people, how you were having to share information and make sure that the different partnerships are all aware just of what's on their local doorstep. That'll be the same right across North West London. So I suppose my question for you really, in terms of engaging with the board for the future, is how long, what's the timeline looking like before you think that there will be substantial sort of strategic value for you to bring to the board, beyond the initial sort of soundings out and just finding out what's working and what isn't. And also just on the, how it relates, to be very parochial, just about Ealing out of the North West London section, how this will benefit our residents particularly, or will we have residents who are actually, getting fast-tracked and finding access to services but having to travel further and beyond the borough perhaps in the longer term?
I'm happy to have a go at answering that, but other members of the ICP leadership team might also want to chip in. I guess I agree. I think your description of what we're trying to achieve at the moment was a good one. I think that I probably undersold, I think, the role for the integrated care partnerships as a way of really trying to make sure that we can represent the views of local people and of the borough in our conversations with the North West London system. And so my organisation, West London Trust, is obviously very heavily invested in the work in Ealing, not least because it's where we're based and have such a large bed base in this borough and the community services as well as mental health. But we're also part of the similar conversations that are happening in Hounslow and Hammersmith. And I can certainly say that there is a consistent theme around ensuring that we are able, especially working with primary care and the local authorities and public health partners, for example, that we are representing the needs of local people in our conversations with the system, whilst we also try to, whilst the integrated care system reorganises itself at scale. I also wouldn't wish to underestimate the ambition, because I think working together, I think we are all hoping that we will be stronger than the sum of our parts, and that we will actually be able to achieve a number of things in a relatively short time scale. So as well as the kind of softer stuff around making introductions, I think we really do hope to achieve some significant improvements, for instance, around diabetes care, and developing these network teams to manage other long-term conditions. And in fact, some of the timelines for that, for instance, in the winter planning paper that we heard earlier, are quite short-term. What can we do this winter to stem demand and to make sure that care and safety is maintained? So I hope maybe that answers the question, some of it.
Yeah, I think you've covered some of it off. It's a little clearer. Thanks, Chris.
And Judith, I think you wanted to add something from.
Yeah. Thank you. Yes, just from a local authority perspective, the ICP is a newly developed system. It's very much about the place, so it's very much about Ealing and what we can do for our residents, and it's about the council and our health and voluntary sector partners joining together to really drive forward the work. It's co-chaired by Dr. Taylor, who's a member of this board, and our chief executive, Paul Nassarak. So that really gives the weight of both organisations together to make the best difference we can for our residents. Inequalities being one of our key drivers, although of course we're still largely dealing with recovery issues from COVID and COVID itself, of course. Thank you.
Thanks. Vijay, do you wanted to add?
Yeah, I just wanted to add, just give a little bit more clarity. So, clearly the NHS is going through a reorganisation, and the ICS and the ICP are key to that reorganisation of the NHS. And there's a great emphasis around partnership working, not just at the place, i.e. in Ealing, but right across North West London. And that's where the ICS and the Integrated Care Partnership is going to be integral to that. And then locally, our four key partners being local authority, our community and mental health providers, general practice, and the local borough team are going to be are key to ensure that we're able to fulfil the priorities of the ICS, but also our local priorities. And this is where our work streams and our work programs have started to be developed, and it is all work in progress, but we are making some good progress already in terms of that partnership working, which I believe will have a significant positive impact to the population of Ealing, which ultimately that is our aim, is to ensure that we maintain good health for our population in Ealing and ensure that they get the right services that they need locally, but also to ensure that if they require more specialised care, that is available across North West London, working in relationship with the ICS and our acute sector partners as well.
Thanks, Vijay. I think, Chris, the question on how we kind of, I suppose, report to is not the right word, because the ICS is separate to the Health and Wellbeing Board, so it's not like you report to us, but how you provide updates is an interesting one, because I think, as we know, many of the memberships overlap and kind of not quite coterminous, but almost. And I think possibly something for us to take away as we go through the next item and start thinking about how we put the Health and Wellbeing Board Health and Wellbeing strategy together, and then how that fits alongside the ICS. So I don't know if it's worth then, Anna, you giving us an update on that as a way of just kind of moving us seamlessly into the next item.
Yeah, happy to. Thank you, Chair. I'm just going to try and share. I've just got one slide just to give us a bit of structure on this. I don't know if you can see that okay. Great, yep. Thank you. So we're in a position where our health and wellbeing strategy ran out a little while ago, but obviously COVID overtook this kind of strategic work last year. We are now trying to plan forward to develop it. It's obviously a massive document that's going to really drive the work of the board over the next few years, so something we want to take time to get right. We have been working on our annual public health report. That's based on the assessment of the impact of COVID on local communities and inequalities. We've brought bits of that here before to update the board on that work, and we're going to be finalising that, taking it through Cabinet early next year. And really the findings and the kind of key principles of work arising from that impact assessment will be used to help develop health and wellbeing strategy. It really covers how we work together as partners, and in the broadest sense across the whole of the community in Ealing, to really help drive down and focus on supporting our communities. So that's really the kind of the proposed theme there, although obviously that's up for discussion for the board in terms of addressing inequalities, building community wealth, and really the importance of whole system thinking. So just in terms of the process, we are thinking of holding some non-public workshops once or twice in spring next year. So really an opportunity for members to jointly develop those draft aims and action plan, really with a focus on what we can achieve as partnerships and how we can each own those actions and take them forward. And those workshops, I'd suggest, would include kind of broader representation, at least from the council in terms of our place colleagues, but potentially some other representatives as well. We have, as mentioned in the ICP update, we have got a new population health and inequalities working group that I chair, and that feels like a really good group to kind of be behind the scenes with the Health and Wellbeing Board and really help drive that forward and help support development of the strategy. And then after we've got at least a high level draft, I'm hoping to go out to some form of consultation on that to local communities probably next spring, summer, and final strategy in place by summer, autumn. And as I said, that strategy
Ah, I don't know if I've lost Anna or everyone has lost me.
I think we've lost Anna, unfortunately. I'll send her a text, Josh, but I think we can see from what she's describing on this slide.
Yeah, so I think it is on the doc. It was circulated as it's on the CMIS page for the meeting. Oh, Annie, you're back. I can see.
Just kicked me out there after one slide.
Was there anything else you needed to add on that? Sorry.
No, that was fine. Thank you. In terms of specific items for the future work programme, we can obviously keep the board updated on that kind of strategy development and obviously kind of ongoing COVID updates. Thank you, Chair.
Thanks. So I think, Chris, it kind of in answer to your question and challenge to us in terms of how we take updates from the ICP, I think as we move back into having the health and wellbeing strategy and this board refocusing on that piece of work as our statutory reason for existing, I think it probably makes sense to then take updates from ICP on specific work programme items and areas of interest, rather than having a kind of a standing item that we feel we just have to populate somehow. If we theme the meetings as the strategy kind of develops and is implemented, we can take items as they go forward, if that sounds sensible. I can certainly see Judith and Anna nodding, and Neha, good.
That's helpful, Joe. Thank you.
Fantastic. So are there any comments from members then on that process of how we get towards the health and wellbeing strategy? It needs a snappier title, for starters. No, fantastic. Well, Anna will continue getting that sorted, and hopefully those workshop dates will find their ways into people's diaries in the coming months. So thank you very much. So those are the substantive items. I think the only question we'd had from Roy that hasn't been covered elsewhere was on the impact of the pandemic on adults with learning disabilities and autistic conditions and their carers. Roy, did you just want to just present that question, and I think Kerry and Chris were going to pick it up.
Yeah, okay, thank you. Sorry, it's rather a long question, but it does cover what we asked at the last Health and Wellbeing Board about the impact of the pandemic and the lockdowns on adults with learning disabilities and people with autistic conditions and their carers. And the report was rather devastating in terms of the loss of daycare, work placements, and lots of other services, health and social care. And we felt we didn't really get an answer as to whether this was the case locally. So, but we did understand that Healthwatch was going to be doing a report and surveying some of the people who'd been affected locally, service users and their carers. So we were unclear whether we were going to have that report at this meeting or in the November meeting. If there is a November meeting, I'm not quite clear about that. So we're expressing concern about people living with autism and people with mental health conditions as well, that they're waiting long periods for assessments and for services to be set up. Can we ask for some statistics? Obviously, can't bring statistics out of the hat tonight, but perhaps you could write to me about this, about the statistics on waiting lists for these groups, and also ask for what measures are being taken by health and social care to alleviate this situation.
Okay, thanks, Roy. Kerry, you do have some statistics.
I do. Thank you, Chair. Thank you for the question, Roy. As I think Matt mentioned earlier, that the Healthwatch report, which has surveyed customer groups, people who use services across adult social care and NHS community services, should be coming to the Health and Scrutiny panel in November. So that will be available at that point. In terms of statistics, the current waiting times for assessments across adult social care is currently, the average is 52 days. We've seen significant improvement on waiting times, and this is the lowest level since April 2020. Of the people there are 168 people waiting assessment, of which 98 have been referred in September. So you'll see that there is approximately 30% who are waiting more than the 28 days, and they're the cases that we're currently looking at. Obviously, within our waiting list and arrangements, we have to prioritise cases for assessment, and that's something that we do on a regular basis to ensure that we're prioritising individuals with the highest level of need. And I think Chris has got some stats as well, Chair.
Great. Chris.
Apologies, I lost Kerry there for a second, but I guess you're coming to me because thank you for sharing the question in advance, Roy. I do have a few numbers from a health perspective related to learning disability and autism in Ealing. And what I can tell you is that we currently have 7 patients waiting for a nursing intervention and no patients waiting for psychiatric assessment. There are 21 patients waiting for psychology, and the current average wait is 4 weeks. From an autism perspective, we've got 35 patients, of whom 22 have been waiting less than 3 months, and nobody's been waiting longer than 6 months. A number of the patients have been brought back from waiting lists where they were being referred to out of area services, and we're now pulling them back onto our local pathway and prioritizing them. So we're significantly kind of close to our kind of targets for all of these. And during the COVID period, for learning disabilities particularly, we put in a health duty system so that all referrals are contacted rapidly.
Great, thanks, Chris. And then, so I suppose, Matt, are you taking that report to the November meeting of the Health and Adult Social Services, or is that a colleague?
No, that would be me.
Fab.
Yeah.
So I think there'll be an opportunity, Roy, for any further discussion on that there. So Matt, thanks for preparing that.
Yeah, can I just ask what the title of the report is? What's the title of the report?
That is a very good question. Bear with me one second. How has the COVID-19 pandemic affected Ealing residents living with a disability and their carers? Should I write it in the chat? It's quite a long one.
Yeah, okay. Yeah, thanks a lot.
No problem.
Thank you, Matt. So that takes us to the end of the agenda. Thank you, everyone, for your contributions. We were due to meet in about a month's time, but I think the feeling is that asking everyone to update the same reports in just about 2 weeks' time is probably a bit much. So I'm proposing that we, given that this meeting was pushed back and the for various reasons, the timetable shifted, that we probably meet then at our January meeting, which I think is the 26th, if members are happy to skip the November meeting. Yes, excellent. So Keith, if you could update systems and diaries with that. So
yes, will do.
Thank you. So I suppose have a lovely Christmas, everyone. But I'm sure many of you I will see before too long in other meetings. But thank you all very much for your time this evening, and we'll reconvene as the Health and Wellbeing